So, first of all, I would like to invite Dr. Mia Muhammad Hanif on the topic of role of diclofenac in pain management. So, sir, your presentation.
Bismillahirrahmanirrahim. Thank you very much and good afternoon, everyone. It's my pleasure. I am a part of this well-renowned and very famous consultants of the town. What I'm discussing today is the pain management and the role of the diclofenac sodium. Uh, this is, this is not from a doctor's perspective. This is from a patient perspective. Uh, this is my disclosure. I don't have any financial interest. So Thomas Edison, I like him very much. He is a great inventor in the U.S. history, and his quoting is, why the people fail in their achievement is because when they are very close to their achievement, they give up. So I never gave up in my life. So being an orthopedic surgeon, Wasif and Shakil is with me. When we are dealing a very complicated operative procedure and we are doing a good job, and after 3 or 4 hours job, when we are going to finish it up, we are very much exhausted at the time. And at that point of time, the patient needs bone graft. And we are very much reluctant, should we go for bone graft or not? Most of the people, they give up. Don't go for bone graft. So the result is the failure. So I like the statement, many of the life's failure are the people who didn't realize how close they were to the success when they gave up. Thomas Edison, he invented bulb, he invented many of the power generator systems, the audio recording system, and the slow motion pictures initially. And he was a good businessman as well. So you must be a good businessman if you treat a pain in a good way. Sorry, there is some problem with the screen. Yeah. Pain. You like pain? I don't like pain at all. Would you label it as a blessing or a curse? Definitely, we don't like pain, but it's not a curse, it's a blessing. So if the pain is not there, you may end up in multiple problems or issues. And I have seen in orthopedic few people in a very young age group, they come up with having insensitivity to the pain fibers, putting their fingers in, they chew up their fingers, they chew up their lips, they chew up their tongue, and the problem is there, they get their bones broken, but they're not aware of the pain. So the most people you are aware of the diabetic neuropathy, they don't feel a feeling of pain, and when it's almost near amputation, they have got the pain. So the pain is, I would label, is a blessing. Blessing in what sense? So if there is no pain, there is no gain. So if I say the pain of a patient is the gain of a doctor, no. Yes, it's true. Because if you treat a patient's pain, you get a lot of money. But along with money, you can get a lot of prayers. वो आपके लिए दुआएं कर रहा होता है और ढेर सारी दुआएं आपको दे रहा होता है. So if the patient is in agonizing pain, I'm sure when you treat it and with first dose of injection, when the patient gets relief, इतनी दुआएं देता है. I think वो दुआएं हमें मिलते हैं तो हमारा बेड़ा पार हो जाए. Anyway, I have got the 60 slides, but thanks to the company, they have deleted all those slides and it's made to 10 or 15 slides. But the key clinical questions we have to ask is how to assess the level of the pain, what adjuncts can be used, and what patient education while discharge. So determine the patient level of pain is very important, and we have to devise the tools, how to assess the level of the pain, and how we will see the improvement of the pain care. And adjuncts, they are very useful to the medication therapy and the pain education, both for the patient and for the doctors as well. So I will later on tell you how it will happen. So what we see in our emergency, we see a lot of patients presenting in emergency with acute pain, either fractures, either acute intestinal obstruction, or acute peritonitis, or acute painful conditions anywhere in the body. So if we look at the record of the physicians and the patients over there, so what we see is the satisfaction of the patient is not. And
it is requested that all the audiences should keep their mic mute while speakers speaking, please. Thank you.
So, Wilson and Pendleton in 1989, they noted several problems in emergency. Why the problem was there? It is the term, very important term, is oligoanalgesia. That's under treatment of the pain. So, if I see an emergency, I go in emergency, I'm looking at the fracture patients and I ask my junior consultants how you treat the patients with fractures. His answer is, sir, I have given Dicloran. So Dicloran is the answer? No, it's not, because the fracture pain is the most severe form of the pain a person experiences in life. So it's the most severe form of the pain. And just a Dicloran is not an answer. So we have to treat it according to the severity of the pain. So what are the factors? Different factors. Factors about masking the symptoms. So the general surgeon says, I'm not going to give a proper appropriate painkiller because it will mask the symptoms of acute appendicitis. So fears about contributing to addiction. So this is another fear. Underestimation of the pain. Because the patient is having more pain, but the estimation of the pain by the doctor is quite less. Cultural differences. So the cultural differences are there. A female patient may be expressing pain more aggressively as compared to male. क्योंकि उसके साथ जो और अटेंडेंट्स होते हैं कि मर्द बनो यार, क्या कर रहे हो, चीख रहे हो तुम, औरतों की तरह चीख रहे हो. So this is the thing, the patient having the same intensity of the pain as a female, but he is not speaking out, and expression is not there. Why? Because he thinks I'm male, I shouldn't express my pain out. But he is feeling the same pain as the other person. And the poor communication between the doctors and the patients. So there is not very good communications and reluctance of the patient to complain of pain and to demand treatment for the pain. Because if you give analgesia just now, the patient is reluctant to say, sir, I don't have appropriate effect of the pain. So I don't have relief of the pain. He will not ask it. So he will somehow or the other will tolerate it. So inadequate training of the doctors in recognition and management of such pain. This is another important factor. So in 2002, Guru and Dembski, they did a study that the patient versus caregiver perception of the acute pain using BAS and numeric rating scale. They found that the nurses and physician rating of the pain was lower than the patient's rating of the pain. So 68% of the patient, look at the calculation, 68% of the patient presented with severe pain, 49% of the patient experiencing no pain relief. So it's two-thirds of the patients. So in Western population. So this much of the population is not having any relief of the pain. So this is important if you look at it. This is very important, and this calls for the need of reassessment of the pains after intervention. So important is we have to assess the pain and we have to treat it accordingly, and we have to understand the pain and the degree of the pain and the intensity of the pain and how the patient is feeling it. So while I went for this pain management workshop, I was knowing I'm an orthopedic surgeon, the patients of mine, they have got a lot of pain. I know pain in a better way. But after this workshop, I was knowing that I was not knowing that my knowledge of the pain and the pain management was not up to the mark. So if you look at the pathophysiology, it's basically a biological alarm system in the body that tells you that something very wrong is going to happen in your body. There are certain factors, internal factors and external factors. External factors include environmental, developmental, and socio-cultural. And the internal factors are sensory, emotional, cognitive, and behavioral. So this a neurologist can understand in a better way. There are two categories of the pain, acute and chronic. And acute pain is associated with injury or pathological condition like sore throat or fractures or the intestinal obstructions. And acute pain is mediated through nociceptors that fire in response to chemicals released during tissue damage, including leukotriene, bradykinin, serotonin, histamine, and thromboxane. Prostaglandins, they act as a local mediator that enhances sensitivity of the free nerve endings and produce pain and edema by their vasodilatory effect. They don't directly activate the receptors. So we will discuss the WHO pain ladder, and before that, we'll discuss the principles of the pain management. So the principle of the pain management, I would rather how I treat my patients. I usually go for proper history, physical examination, and the investigations. But during history and physical examination, this is very important not to neglect pain. We have to give a proper painkiller during history taking and during physical examination. It's not the way that you are taking whole of the history, physical examination, you are sending for the investigations and you are not treating the pain. But before that, we have to continue the painkiller and that we have to treat the pain first. So in history, this is very important. That the actual history, with actual history, we must know the patient having acid peptic disease, patient having any renal issues, any liver issues. So we have to consider the other problems as well along with that. And we have to fulfill our treatment according to the condition of the patient. So in physical examination, we see the 4 vital signs, and the pain is a 5th vital sign now these days. So we have to treat. So this is basically the priority, how to treat and how should we consider the pain. And we have to treat pain on priority as the vital sign. So this is the 5th vital sign. We have to keep it in mind. We have to go for pain control. That must be individualized according to the condition. If the patient having mild pain, you can give it oral painkillers. If the patient having moderate pain, you can go for intramuscular injection. But if the patient having severe pain, you have to go for IV injections. Now, how to titrate it? So we'll discuss later on. So anticipate pain rather than react to it. So if the patient having fracture of the limb or intestinal obstruction, we have to understand that the patient is in severe pain and don't react to it. Don't make a shut-up call to the patient. So this is very important. So let the patient control or moderate her own pain. Because in certain painful conditions, the patient feels a relief of pain in certain postures. So we have to encourage that posture. We don't have to ask that this posture shouldn't be adopted. And the pain control is best achieved by combination therapy, including adjuncts. So adjuncts are very important. So if the patient having a lot of swelling, we have to elevate it. We have to go for continuous movement of the toes of the limbs, so that the edema to reduce edema, and we have to go for cold sponging to reduce that. So now I come to the World Health WHO pain ladder. So this is we have to start with 1, 2, and 3. So in first ladder we have to go for non-opioid NSAIDs, and along with that we can go for adjuvants. But in moderate pain, we have to go for opioids for mild to moderate pain, along with non-opioid or adjuvants. And in a moderate to severe form, we have to go for opioids. We have to go for first opioids, along with non-opioids or adjuvants. So these are different adjuvants. Benzodiazepine, mostly used by the neurologist, but other people can also use this medication. Anticonvulsants, carbamazepine, gabapentin, phenytoin in chronic pain, they are very useful. And caffeine, and with a dose of 65 to 200 milligram, is very effective in headache, oral surgery, and postpartum pain. Hydroxyzine. This is anti-emetic drug, and this potentiates the effects of the opioid. So if you see the people who are the drug addicts, they are using hydroxyzine along with nalbuphine. So they think it's a good, analgesia or some sort of. They have good satisfaction with hydroxyzine. Corticosteroids, they can be used in certain conditions, especially in in tendinitis. It's a antidepressants. They are also useful in neuropathic pains, especially in fibromyalgia. So the neurologist will tell all these drugs in a better way. Muscle relaxants, very good role. So in acute muscular spasm, muscle relaxants have a very good role. Ergotamine, again, used by the neurologist for migraine. It's a very good drug, but there are certain contraindications to this. So now, after that, the adjuvants are the elevation, immobilization, ice, and tense. That's very, very good. Now, after his history physical examination, we have to go for pain assessment tools. So there are different pain assessment tools. It's a visual analog scale, it's a verbal rating scale, it's a verbal descriptor scale. So anyway, whatsoever it is, the best way is what I do in my setup is totally different. Because जो पुराने लोग होते हैं, they are very well aware of ANA scale. So this is article published in JPJS from Pakistan. And they use ANA scale. जो पुराने लोग हैं, they know very well कि 16 आने क्या है, ₹1, और 8 आने क्या है, 4 आने क्या है, कि रुपए में से कितना फर्क पड़ा. So we say that आपको कितना दर्द है, कहते हैं रुपए की 16 आने. We give some analgesia and we ask how much of the pain you got relief. And the patient says रुपए जो 8 आने हो गया. So it means 50% is okay. अगर वो कहता है कि रुपए में से 4 आने हुआ है, रुपए में से 2 आने हुआ है. So this is how you go for description of the pain. The other ways जो आजकल के दौर में है कि 100 पैसे हम कर लेते हैं कि 100 पैसे में से कितना फर्क पड़ा आपको, ₹1 में से 100 पैसे में से 50 पैसे हुआ, 25 पैसे हुआ, 10 पैसे हुआ. So this is how you go for a description of the pain. So this is very important, and then the patient in our setup, they can understand this term very well. So after that, I will go for management of this pain. That management of the pain depends upon the etiology of the pain. And there is a lot of swelling, you have to apply a cold sponges over there. And in cases of acute intestinal obstruction, you have to go pass NG to relieve this discomfort and pain. Basically, in the management, NSAIDs are the mainstay, but we have to go for opioids according to the situation and according to the pain condition. So what happens is the pain message usually is passed with when there is release of endogenous opiates, enkephalins, and dysnorphins, serotonin, and norepinephrine. And the tricyclic antidepressant, they act by preventing reuptake of serotonin and norepinephrine. So they have got a good role, antidepressants. So anticonvulsants, along with the NSAIDs, they have got a very good role, and gabapentin, they work at the peripheral nerve level. So the neurologist can tell us in a better way. And we have to use in certain cases and with very good results. Similarly, the antidepressant and the anticonvulsants, both, they can be used in certain cases of neurogenic pain. How we go for an emergency? A patient comes to with mild pain, we have to address it in a better way. How we go for? We can go for oral analgesia. If it's a very mild pain, we can go for intramuscular injection. In certain conditions with mild to moderate pain, but we don't have to go for intramuscular injection in cases of fractures because the patient may get relief after half an hour. For half an hour, he has to suffer in this condition. So we have to use IV opioids in cases of fractures and in cases of very severe pain. So there is very limited role of this intramuscular injection in very severe pains. The other thing very important is being an orthopedic surgeon, and we go for what I do is my practice is I ask the patient before that, I was not going to ask from the patient the day after surgery, how was the night? रात कैसी गुजरी? The patient answer is, I was in a hell throughout the night. I was in severe agonizing pain, never experienced in my life. Doctor, I couldn't sleep for a minute even throughout the night, for a second even. एक second के लिए नींद नहीं आई. अच्छा. So last time क्या हुआ कि I went for total knee replacement and there was epidural catheter. So I was quite confident there won't be any pain in the morning. So I asked in the morning कि रात कैसी गुजरी. So I was confident कि दर्द बिल्कुल नहीं हुई होगी. And the patient said I was in a severe pain. So I asked the attending physician over there why the patient was having pain. And he said, anesthetist told me that you have to go for this much of the injection, not more than that. So basically, they were not titrating the pain intensity with the dose. So they must have to do it. Now I asked him, the patient was in agonizing condition, you must give some IV opiates, you can give some intramuscular injection along with that, or you can go for some levomethacin drip along with that throughout the night. You didn't do anything. So now the patient said, I went for total knee replacement on this side. The other side, I will not go at all because I was in severe agonizing pain. So मैंने उसे पकड़ा, मैंने कहा भाई मेरा 3 लाख का नुकसान हुआ, ये तो मेरा पूरा करो. So this is a condition mean के certain अच्छा. The other patient I went for total hip replacement. The other day patient was in agonizing pain and बुरी हालत में था. तो मैंने उससे पूछा कि what happened? And he said I couldn't sleep throughout the night. क्या हुआ? So I asked the attending doctor over there, duty doctor. So what happened to the patient? And he said I have given 3 Nelvin, this much. But the patient was having acute urinary retention. So I passed just a Foley's catheter and the patient pain was relieved. So sometimes you're not looking for the pain is, the cause of the pain is this. No, that's not. You have to see each and everything. You have to keep it in mind as patient as a whole. And it's better to take a feedback from the patient the day after surgery. Okay, we come to the mechanism of action of NSAIDs. So basically, my stress was to understand the intensity of the pain and from patient perspective. And we have to treat the pain on priority according to the condition of the pain. So one patient staff asked me, sir, the patient is not having any relief of pain. I have given 2 Nelbin injections, 1 Decloran, 1 Toradol, 1, okay. And the patient has no pain relief. So this was supracondylar fracture of the femur. So I asked, you have to go for some LELAP injection, lagosamide, half injection IV stat, and he was having no relief of pain. So I went for femoral block. And after 2 minutes, patient was quite relaxed and without any pain. So we have to see, as a patient, what we can do for the patient and to relieve the pain is the priority, basically. And the patient is in agonizing pain, Anyway, the mechanism of action is basically the arachidonic acid, which is released from the tissue damage, is metabolized by the COX-1 and the COX-2. So this COX-2 will form the prostaglandins, and the COX-1 will, the prostaglandins formed through the COX-1 route. They are protective for the GI, for the platelet, and for the kidneys as well. So the non-specific NSAIDs, they act both on COX-1 and COX-2, and they basically inhibit the prostaglandin formation, which mediate pain and inflammation. And certain COX-2 specific analgesics, they are used but having more effects on cardio. So I better go for certain NSAIDs with very short half-life, because the short half-life, it gives some time for the prostaglandins to rejuvenate for some time. So there is period of relaxation, you can say, for the prostaglandins, especially for GI mucosa and for the kidneys. So the long-acting, with long half-life, 48 hours, if you give, then they can't rejuvenate. So they affect the kidneys and the GI mucosa more as compared to the very short-acting NSAIDs. So pharmacological treatment of the neuropathic pains, topical agents can be used like lidocaine, opiates can be used, antidepressants, tricyclic, and SNRI can be used, duloxetine by the neurologist, and especially in cases of neuropathic pains in diabetics. Anticonvulsants can be used, carbamazepine and the valproate. The intrathecal ziconotide and opioids can be used intrathecal, especially in epidural injections. So the pain, I'm going to conclude my talk. The pain education program. This is very, very important. It should be a 4-hour education program for the junior and the senior consultants both. This was found to increase the improvement in treatment of the pain. And the curriculum should include the causes of the pain, pathophysiology, principles of the pain management, types of the treatment, and how to customize treatment plan for pediatrics, elderly, and the patients with abdominal pain. This is a very good drug. In most of my cases, I use this brand. I like Voltaren 50. I usually don't go for this Voltaren SR100 because I don't want to damage the patient's kidneys and the GI. But the Voltaren 50 is very good drug, and it's being used for the last 40 years. And we don't have any, but there should be some precautions while choosing this drug, and we have to consider the GI upset and the renal problems along with it. Thank you very much.
Thank you very much, Professor Hanif, for a very comprehensive and very informative talk on pain management. And obviously, you shared your expertise, your experiences about the pain management. So I'm sure that the audiences would have definitely got a lot of information from this talk.